All right, here we are again, recording after a bunch of technical difficulties.
Yeah, dropped my lemonade in the floor.
Yep.
My whole lemonade.
Yep. Couldn't figure out the microphone. But here we are.
I still don't know why it's working now and it wasn't working before.
Yeah.
But it is. Today we're going to do something a little different, though. We're going to actually tell a little story with our education today. We're going to be discussing cardiology.
Yep. Cardiology.
Well, cardiology is great because there's a lot of things that, 12 leads can tell us. Maybe not relative to some of the things that we do, but we can learn a lot about the patient. It's minimally invasive. So I really like cardiology.
Fair.
This little man right here, though, he has a series of just things that happen to him that just aren't really good at this point in time. He's such a cute little man, got his little suspenders on and everything. His name is Mr. Jackson.
Mr. Jackson looks like Humpty Dumpty a little bit.
Well, he's short and fat, kind of like me.
I love that men can just wear suspenders to keep those pants.
Well, I wish I could
for the rest of their life.
He's a good guy, though, and we're going to talk about him today. We're going to tell you his story.
All right.
Mr. Jackson is 72 years old. He lives at home with his cat. His wife passed away probably about 5 years ago. He has a brand new grandkid. So he's pretty happy about his grandkid. Stays right there with his little cat. I can't remember the cat's name.
It looks like Pete the cat. If you had kids, you'd know what I'm talking about.
Okay.
Pete the cat.
So our story begins with Mr. Jackson. He lives at home by himself. Mr. Jackson was at his house, just had finished a good lunch of a ham sandwich and some Lay's potato chips, much more than I've had today.
Yeah.
Mr. Jackson was just about to turn on the daily news when he felt a sharp pain in his chest. Mr. Jackson had never felt any pain like this. Mr. Jackson thought it was the weirdest pain as it almost made him short of breath. As a feeling of doom came over him, he decided he must call 911. So he took out his jitterbug iPhone there.
I knew you were going to say jitterbug.
Called 911. Because after all, he didn't want to die home alone. He had lots to experience. The growth of his brand new grandchild. 911 dispatcher picked up, and she asked him a series of questions. First, where he was calling from, what his address was, what his telephone number was, just in case they got disconnected. And then ask him about what was going on. Ask him questions about his chest pain. She assured him that she was sending the closest ambulance to his house and offered to stay on the phone with him. Sweet little lady.
That's nice of her.
She wanted to stay on the phone with him until they arrived. And Mr. Jackson said, "No, I'm going to be okay. I actually need to put my cat up. Cat's name is Nibbles. And I got to put him away because if they get here and leave the door open, she'll run outside."
Sure.
So he disconnected with the 911 dispatcher, and they sent the closest unit out to him. Just like that, there was a knock on the door. Mr. Jackson was so weak at this point in time, he was already kind of laying down on the couch, and he yelled up to the EMTs, "Miss, please come in. Please come in."
Yep.
EMTs and paramedics found Mr. Jackson lying on the couch. Let's talk about this physical presentation to begin with, though. What do you see?
He's pouring sweat.
Okay, so diaphoretic.
Yeah.
You don't obviously see that any kind of Levine sign or anything like that, because it'd be hard
What's
to...
Levine sign?
Where, he's kind of clutching his chest, and clutching his chest. You can obviously tell, like kind of the universal sign of chest pain. You can obviously tell that he's in some discomfort. If it was...
But it's not like 95 degrees in this house. Like, he's sweating because he's got cold sweats. Is that what you're saying?
Yes, ma'am.
Okay. Carry on.
As he clenched his chest and struggled to breathe, the EMS personnel began to investigate what was wrong with him. Mr. Jackson obviously recognized that something really terrible was going on. EMTs and medics were asking him questions Could he describe the pain? Does it move anywhere? Was he allergic to anything? When was the last time he ate? What was he doing when the pain started? Does it hurt worse if they push on it?
What do you think about that question? Does it hurt worse when they push on it? I've read a bunch of studies where they say that doesn't mean crap. And then, I'm sorry, this does hurt.
Mm-hmm.
It hurts. It doesn't matter if you had pain there or not.
So I'll go ahead and tell you from a pre-hospital provider, reproducible chest pain on palpation is something that we look at quite a bit to try to steer us away from cardiac chest pain.
I know.
It is. So try to steer us away from cardiac chest pain, which is why you see that on a part of so many providers' assessment. The way that I look at reproducible chest pain, I don't really care.
Yeah, it doesn't change anything. Like, you're not going to, like, hang your hat on, like, oh, this guy's, like, 70-something, and he's got, like, costochondritis. I guess I'm going to send him home without doing an EKG. Like, you're never going to do that.
No, I really don't care because, with this gentleman right here, to start with, he's in his 70s.
Yeah.
So if he told me he was,
doesn't matter.
He was working out and felt something pop and I pushed on his chest.
Or he fell off something,
yeah,
right? Like
I'm still going to do an EKG.
Still going to do an EKG.
Yeah.
Because it costs pennies to do one, really.
And then the other thing is he's diaphoretic. This patient also has
that should make you stressed.
Yeah.
All right,
so
anyway.
they were taking his blood pressure on top of giving him aspirin and would not allow him to drink any water. Yes, he was like, "Can I just swallow this?" They're like, "No, you need to chew it."
Thing, you could just, right. They want him to chew it.
Yeah, you need to chew it up. Mr. Jackson wanted to cry as they cut his suspenders.
Oh, because he knows he's got to get them pants up. I told you.
Cut his suspenders in order to put a bunch of stickers on his chest. Swiftly and quickly they moved and then asked him to remain still as he could. How could he be still? They told him it was very important that they were trying to get a picture of his heart.
That's fair. Oh boy. Yeah, it's looking like Mr. Jackson's going to have a rough go here.
So they are letting this thing print out on their monitor. They're already seeing in their inferior leads. Oh, we'll talk about it in a second. Let's just let it continue to print. All right, so 12 lead comes out, and immediately we recognize significant elevation in our inferior leads.
Sure.
So let's talk about the size elevation. Let's talk about how it's presenting, what you get off of your spidey senses and things that make you cringe looking at this EKG. You start with elevation where?
Sure, 2-3 in ABF.
Okay. So we have what we think is the bottom of the heart being affected, the inferior wall. Mm-hmm. All right, so when you make a diagnosis of inferior MI, what are the other things you look at?
You want reciprocal changes, and so you see some depressions in AVL. There's a little bit of depressions already in 1. I mean, plus minus some depressions and 2-wave inversions at AVR, but that can sometimes be part of what somebody normally looks like. The other thing is that I have no idea what medicine this guy's on, but he's in extreme pain and he's bradycardic, right?
Typically, that's not in my findings though, and I know you've seen a whole lot more STEMIs than I have, but in my finding, that's not typically abnormal, especially when it comes to the inferior
wall. But you'd
wall.
want it, like, technically. Yeah. You'd want him to have, like, tachycardia due to pain, but he doesn't.
For the people that haven't been in paramedic school in a while, or maybe might not even know, let's talk about the importance of reciprocal changes. Mm-hmm. Let's talk about it really quick.
Well, you always look for them, right? Because, I mean, it makes sense that the opposite side or the opposite polarity where the various leads were going to be ischemic as well. And so it just means that ischemia is continuing. You can see it with depressions in the area outside of, on the opposite side of the 2-3 and AVF here, more or less. And so if you see a guy like this and you don't have reciprocal changes and this is what the EKG looks like, you're still going to call a STEMI, right? Like, it doesn't make sense not to. But there are people around, and I had a guy a couple weeks ago that you're like, no, this looks like a STEMI, but you look at his old one and there's no reciprocal changes, and the old one looks exactly the same, and you're like, okay, no, this is just how he looks.
Let's also talk about how the elevation presents. Is that important to you? Because there's really like 3 different ways that elevation presents.
You mean like
Convex,
yeah, sure.
concave.
Sure.
So what would you describe this as?
I mean, these are concave, right?
Yeah.
So, I mean, they technically, you can draw a happy face, a smiley face in there, and that should make you feel better. Although it really doesn't in this case, because you look at the whole patient,
Let's
right?
look. You say concave.
Yeah. I think that's what this way, right? Isn't that what I'm...
Well, those words are weird.
Well, and then the convex one would make you think, oh, that's more ominous, if you will.
So the depression mostly kind of matches, I would say more convex. Would you agree?
You think with this?
I don't know, but does it tell you anything? Not really.
No.
Just that it's there,
No.
right? Okay.
No. But the picture tells you things in its entirety is what I mean. All right.
Mr. Jackson asks, can someone please tell me what's going on? And I think this is very important for a patient because we do forget that the patient is the one that called you, and we should update this gentleman. What do you tell Mr. Jackson?
I said, Mr. Jackson, you're having a heart attack, and it looks to be pretty major. By what I can see on the EKG, we got to get you to the hospital quickly. Is
there anything that you tell him that, because you tell me I'm having a heart attack and it looks to be major, it's automatically going to make my anxiety go up. Any tips and techniques there?
I just say the same thing. We've got to get there quickly. There's going to be a lot of things said at once. Just take a deep breath, and I'm going to update you and tell you more on the way to the hospital.
But Mr. Jackson looks at you and says, Sarah, how can this be? How can this be? I know I'm a little heavy set and don't necessarily take good care of myself, but I've been feeling great recently.
And I think it's important that the paramedic informs Mr. Jackson. He'll be glad to get into detail on the way to the hospital. That's the right move, right? So you get in there and say, listen, I'm going to tell you all about that on the way. And here's the thing. And then, of course, they put pads on the chest, which makes sense.
Just before they go.
They should.
Just before they go out, they put pads on the chest.
Which is smart.
Why? Why is it smart?
Because you don't know how this could go. You don't know if he could decompensate into a fib and need to be shocked, or VTAC need to be shocked. You don't know if he's going to code and needs to be paid. There's a lot of things.
Okay, how often you being in the ER where that patient maybe comes in and is not stable enough to go right up to the cath lab, there has to be some resuscitation. But how often do you see it?
On there already?
No, how often do you have you ever seen where they went into fib or TAC?
Oh, it does happen.
Quite a bit?
Happen.
Okay.
Yeah. I mean, it's enough to be concerned about. The other thing is that you tell this guy on the way to the hospital about, just be very upfront. That's what they tell you is the easiest thing to tell a patient. Be very clear and concise. Don't use a lot of medical lingo. Like, just say, this is how a heart attack works.
Do you want me to show you how this paramedic handled it? This particular paramedic handled it by the treatment that he was doing for him. I think it worked very well. Maybe somebody has a different technique of trying to calm down the patient, especially if they're having anxiety. First off, we need to go ahead and talk about this inferior wall MI. What do we know about an inferior wall MI? First off, we've already said it's affecting the bottom of the heart. And let's spend a little time there because we need to talk about that. With it affecting the bottom of the heart, which 2 chambers are really taking a hit there?
Right ventricle.
Which tells us what? If it's the right ventricle or the ventricles, it tells us this particular heart attack is going to be very preload dependent, right? Because it's not able to push that pressure up to be able to allow for good afterload for good circulation, right?
Right, and these are the people that go into CHF.
This is also more for us.
Sure.
These are the patients that we drop their blood pressure, that we do harm to them based off of some of the medications that we give.
Yes, we got to watch it.
So there's 2 medications already that we're thinking about that we would give this patient that is having this 10 out of 10 chest pain with Levine sign is morphine and nitro. And we know both of those are going to have a direct effect on our preload, right? Preload dependent.
That's right.
Very, very, very preload dependent. So the paramedic tells him while he's on the way to the hospital, he says, Mr. Jackson says, Sarah, where you're the paramedic here. You've always wanted to be. You freaking took your EMT. So he says, Sarah, what's to come for me? What's going to happen to me? Is this the end? And the patient bluntly asked what's to come for me? What do you tell him? What do you tell him about what's going to happen at the hospital?
I tell him a lot of things are going to happen at once, but the main thing that they're going to be doing is preparing him to go to the cath lab, and that's a place that they can open this artery up.
I think it's very important that you be very descriptive with him where they're going to come in to
it could be in the wrist, it could be in the groin.
Right.
They put a wire up there and they try to balloon open the artery that's the issue and usually put a stent in there. Keep it open.
You tell him all that, and believe it or not, he doesn't have much medical experience, but he understands. He's like, good. Okay, I understand. Thank you. But you gave me aspirin back there.
Yeah.
What for? And how much aspirin did you give?
324.
All right, you gave me 324 milligrams of aspirin. I don't even have a headache.
We gave it to you for your chest pain.
Okay, well, let's look at this. Because he's curious. Well, what you gave it to me for my chest pain. I've only ever taken it for a headache. So right here, you say, well, let me draw you a picture. And you kind of shade it in right there.
Nice.
And you draw that picture. Sure. And what have you drew here?
Well, we drew the artery.
Okay.
We drew the narrowing of the artery and the clot there.
Right.
Right? So, as the clot forms, this COX-1 enzyme kind of secretes stuff.
So, all right. So you drew, Mr. Jackson, this artery. You drew most likely what is going on. You see the clot here, and you see the platelets start to kind of clump right there together because it's not flowing as good.
That's
right? It's not the blood's not flowing as good. So, and then you have these COX enzymes, and these are very important for what we talked about a couple months ago with trauma.
That's right.
These platelets are very important, but the body's own mechanism is kind of going against it
itself
here.
Because we don't really need it right at this
right. We want to do away with that COX-1, right?
Right.
Because it's throwing out what is it called, prostaglandins whatever,
and it makes everything sticky.
Yeah. So we're gonna release some aspirin,
and
we're gonna take that aspirin and it's
deactivate.
It's gonna find the COX-1. It's gonna deactivate it. Take it away.
Boom.
Continues through the artery. Finds some more COX-1. And my easiest way to illustrate that right there is it comes together and it just deactivates it. Keeps
I think that's the easiest way to explain it.
Do you like that?
Sure.
All right, so Mr. He despite some of those terms like COX-1 and things like that, he's starting to get it. So he says, so this is not going to break my clot down, Sarah?
Not necessarily.
So,
no.
But, so it sounds to me like it keeps it from this COX-1, does it make my clot sticky? Or does it make it easier for...
It makes it easier to form a clot. Maybe that's what I want to say.
So if someone had stabbed me, I would want my...
You want it there.
Yeah.
But you don't want it there now.
So you have to give me this 324 of aspirin.
Yeah.
I get it. I understand. Mr. Jackson must be a visual person as well.
I'm a visual.
So is there anything else you're going to give me? Is there any other medication that you would like to give me?
Depends on the vital signs.
What do you want to know?
I want to know what his blood pressure is.
Well, you got to put one of those cuffs on my arm, which you did in the house. So, I guess you're going to retake it? Retake my blood pressure?
Retake it.
Okay,
yes.
You retake my blood pressure, and you see my blood pressure is now 140/90.
Oh, we probably have some room, but we're going to have to be real careful with it. Like if you want to give nitro to help relieve some of the pain and help open up dilate the arteries, that's fine. It's just that, again, where this is an inferior, and you just got to watch it. Now,
Sarah, Mr. Jackson here, I need you to explain what you're talking about.
Well, I want to give nitro.
Okay.
Help dilate everything.
Nitro, I know, like nitroglycerin?
That's right.
My wife was on that. So what are you wanting to give it to me for?
The chest pain, to help kind of dilate the artery that's...
Is it going to take my chest pain away?
It may help a little.
How?
Well, if we dilate that, then more blood flow can get by.
But you keep saying that you might not want to do it because you're worried about my blood pressure.
That's right, because if we drop your blood pressure too quickly, this is a preload dependent state like we talked about. So we need the pressure to kind of maintain within normal. It can drop pretty precipitously.
So dilate, when you said dilate, that's to make it bigger, right?
That's right.
Like when they dilate my eyes, because I wear glasses.
That's right.
So that was to make it bigger. So that's going to allow the blood to flow through and maybe get around that clot that we see.
That's right.
So that will help my pain.
It should, a little bit.
Because now I'm getting more blood pumped to my heart.
Yeah, and there's less parts of your heart that are dying.
But when you dilate that, you're going to probably make my blood pressure go down because there's not going to be as much pressure on the wall.
You got it. So we got to be careful.
I understand. What is there anything else you want to know before you give me nitro?
Just allergies.
Okay. Well, what about, do you want to see a right side of my heart?
We could, but it's not going to change what we have to do. But sure.
Well, it would be good clinical practice, right?
It may. Sure.
All right. So how do we do that? We're going to just move V4 over to the right side, right? We're going to take another picture, and you look at this picture right here, and it looks about the same.
Yeah, it doesn't look any worse.
No, it looks about the same, and you have labeled it here V4R.
That's nice. That was really thorough, wasn't I?
It was. That was top-notch care there.
Top-notch care.
So this right here, that based off of this, you don't have a suspicion that your right ventricle is involved, which typically this kind of STEMI right here, a lot of times, probably up to 50% worth of the time that the right ventricle is involved.
Right.
So you see that you don't have that going on here. So what are you going to do for me now? You took my blood pressure. You reassessed this 140/90. You're okay to give me some nitro?
Yeah, with an IV in place and make sure we have fluids hung.
An IV in place and some fluids hung.
Yep.
Let's see if we can get that established.
Look at that.
So we got an IV established. And got some fluids hung. You just doing something just to try to make sure you maintain my blood pressure.
Right, and if he drops, we can give him a bolus of fluid. Try to right back up.
Yeah. All right, so we got that established, and you're okay to give me some nitro now?
Sure.
Anything else you want to know?
Oh, if I took any erectile dysfunction medications.
I think it's Viagra and Cialis, right?
That's right.
Yeah, Viagra is at 24 and Cialis is 36. I can't remember.
I don't
but
remember.
Either way, if they tell me, I'm probably going to withhold. All right, so you put this in my face and you hand me that nitro and you tell me, put it up under my tongue.
Yeah.
Let it dissolve, and sure enough, it helped. It helped. Am feeling a little dizzy though, right now.
Yeah, let's check that blood pressure again.
So check my blood pressure and it's 114/60.
That's not terrible.
Not terrible at all. What else do you want to know though? Are you still having pain?
Yeah, sure, that's a good question.
Are you still having pain? Because if he's not still having pain until he starts to have pain again, we can probably withhold on that, right?
That's fine.
Yeah,
Right.
so I'm all about when you give somebody medication, you gotta be indicated. Gotta be indicated, right? You don't interrupt the body's natural mechanism.
That's right.
Here's the sad part, though. We get him to the hospital. Mr. Jackson goes into cardiac arrest. Doctors work hard to resuscitate Mr. Jackson. After 2 defibrillatory shocks of 200 joules, a return of spontaneous circulation is achieved. Mr. Jackson is then moved to the cath lab.
Let's look at the report.
So it's good that we put those pads on the patient.
It's like y'all knew. It's like you've done this before.
All right, so STEMI alert comes out. Mr. Jackson, we find out more about this gentleman. He's 72-year-old male. He does have risk factors. He had a previous MI with stents placed. Also has a history of hypertension. Onset of chest pain after eating lunch, and he called 911.
Well, why do you act like he can't remember that? If this was his first rodeo.
Well, take us back to an episode to where you asked me if I told you could ask the patient if they have a left bundle branch block, and you say they're not going to be able to tell you. They're not going to tell you because they don't know.
I know, but why do you act like you've never been through this?
I can't tell you why.
All right.
Probably to allow us to do this presentation.
Fair.
Because if he would have knew all this, then we wouldn't have been able to explain this to him today.
Is it fair? I don't know. All right,
So,
go ahead.
EMS takes him to the ED, and on arrival at the ED, patient experienced a VFib arrest, ACLS with defib ×2, intubated in the ED, and then to the cardiac cath lab. Peak troponin was 104.8.
Nice.
Okay.
All right.
All right, so let's look at this right here. We've got a 100% occlusion of the RCA, which is not throwing us any tricks at all. When we see typically in the inferior wall, that's the artery that's going to be giving us the trouble, right?
Yeah.
Anything you want to talk about here? Because this is more your wheelhouse. All I see is that not good perfusion, and now we have good perfusion.
That's good.
Okay.
Yeah.
Extubated in the CCU, repeat episodes of VTAC and VFib in the CCU, and after a recovery on a telemetry unit, patient was discharged home. I'm not going to say what with, but he was discharged home. This is Mr. Jackson spending some time in the hospital. Obviously, he is ready to go home, and he's not happy with the amount of time that he's having to spend here. He wants to see that brand new grandkid, but he knows that it is very important. He's a very sick man. It's very important that he get himself rehabilitated and get some things, taken care of for himself. During his stay, he can't think of nothing but his family and his grandkid. Sweet, sweet man.
He is sweet, Mr. Jackson. Turn on a dime on it, won't he?
Well, he did. He's not happy with you now.
No.
He's like, I'm ready to get out of here, and when is my day coming? And this doc comes in and says, Mr. Jackson, we're actually was just talking with a social worker about getting you out of here.
That's wonderful.
Wants to get him out of here, wants to get him back home, and he hands him this thing right here.
Sure.
Hands him this LifeVest that he's supposed to wear.
Yeah.
What do you think Mr. Jackson says?
He doesn't want to wear it.
He doesn't have a problem wearing it,
He
doesn't know what to do with it.
He doesn't even know what it's all about.
He doesn't. Nobody has told him anything,
Sure.
and if you can look at the look on his face, you can see that Mr. Jackson's not okay with that.
Yeah, he's got the slanted eyes. He's perturbed.
So we're gonna move you up to the floor, right? We're gonna move you up to the floor where the CCU is, and you're gonna get the brunt of this. Sarah, you've been taking care of me for a week, and you haven't told me anything about this vest you want me to
It's okay. I've got a really great video for you to watch.
You got a great
It's gonna
video.
be amazing.
So how are you gonna watch the video? You're gonna pull this TV in here for me.
Yep. Look at that.
And you're going to go into detail. But before we go into the video, let's talk about the LifeVest. Let's talk about why they're probably sending him home with a LifeVest.
Well, he had a lot of arrhythmias after,
Mm-hmm.
and he had a VFib arrest prior.
Mm-hmm.
And that's by and large probably why. But he also needs to his heart needs to heal some before they want to put a permanent.
But they're already at the hospital. Why can't they just put a defibrillator in?
I would venture to say that he maybe would have had one, but they also need to give his heart time to heal.
Okay.
That's my thought.
So just a little, maybe buying some time, something temporary.
Yeah.
Cool. Well, the next thing what we'll do is Mr. Jackson will get the education on the LifeVest.
They usually come into the ER carrying it, so that's really good.
Cool.
It's really good.
The following video will provide a brief overview of the LifeVest wearable cardioverter defibrillator, also known as the LifeVest WCD or LifeVest, and includes information that will be important for you to consider in the event that you encounter patients wearing the device. LifeVest is a wearable defibrillator that offers at-risk patients protection against sudden cardiac death. Unlike an implantable cardioverter defibrillator, LifeVest is non-invasive and is worn outside the body rather than implanted inside the chest. LifeVest consists of two main components, a garment and a monitor. The garment is worn under clothing. It is designed to detect certain rapid life-threatening heart rhythms and deliver treatment shocks to the heart when necessary. The monitor is worn around the waist or from a shoulder strap. It is designed to monitor the heart, record arrhythmias, and determine when treatment is required. Electrodes are contained in the belt around the body. ECG electrodes continuously monitor the heart rhythm. Therapy pads deliver treatment shocks to the heart when necessary. On any given day, tens of thousands of patients have protection by wearing the LifeVest WCD. LifeVest is used for a wide range of patients, including those who have a reduced heart function following a heart attack, before or after bypass surgery or stent placement, or for those with cardiomyopathy or heart failure that places them at particular risk. Patients who have had an implantable defibrillator removed and are unable to be immediately re-implanted for whatever reason are also prescribed LifeVest for protection until the re-implantation procedure. The LifeVest system uses 4 ECG electrodes around the patient's body. One pair of electrodes provides a side-to-side channel of the ECG signal, and the other pair of electrodes provides a front-to-back channel. When a treatable ventricular arrhythmia is detected, LifeVest initiates a sequence of alerts and voice prompts to warn the patient and bystanders of a possible treatment shock. During this time, if the patient is conscious, they are instructed to press and hold the response buttons, which are found in the top corner of the LifeVest monitor. The response buttons prevent a treatment shock from being delivered. Please note that only the patient should press the response buttons. If, however, the patient is unconscious, the sequence will run through a 5-second vibration alert, followed by a low single-tone siren, which is broadcast for 5 seconds, followed by 5 seconds of loud 2-tone sirens. The device then transitions to voice prompts accompanying the 2-tone siren. In order to quickly and effectively care for a patient wearing the LifeVest WCD, it is important to understand the different alerts and voice prompts that may be broadcast from the device. If the LifeVest device is silent when you arrive on the scene, the device may be monitoring the patient's heart rhythm. If, however, you arrive on the scene and you hear a single-tone alert or a gong from the LifeVest WCD, the device may be alerting the patient to follow instructions displayed on the monitor screen. In some instances, the gong alert may also be accompanied by a voice prompt.
Treatment has been given. Call your doctor.
In these situations, you should proceed with standard evaluation and treatment measures. If external defibrillation is available, a decision can be made to remove LifeVest and monitor or treat the patient with your own external monitoring and defibrillation equipment. To disable the LifeVest WCD, simply pull out the battery. You can then unclasp the hooks at the front of the garment and remove the device. If you arrive on the scene and LifeVest is broadcasting alerts or voice prompts, it is important to pay close attention to these messages. Audible 2-tone siren alerts and voice prompts may indicate that the patient has been treated or is still in the process of being treated. You may hear the 2-tone siren alerts accompanied by this prompt.
If patient is not responsive, call for help. Perform CPR.
These prompts mean that LifeVest may be detecting an untreatable rhythm, such as asystole, is unable to detect an ECG signal, or may have delivered the maximum number of treatment shocks in a treatment sequence. In these situations, proceed with your standard evaluation and treatment measures. You may decide to disable and remove LifeVest and use your own monitoring and defibrillation equipment. Again, to disable the LifeVest WCD, simply pull out the battery, then unclasp the hooks at the front of the garment and remove the device. If LifeVest has detected a ventricular arrhythmia and is preparing to treat the patient, the 2-tone siren alerts will be accompanied by this voice prompt.
Bystanders, do not interfere.
When LifeVest is in this mode, an electrical shock will usually be delivered between 25 and 60 seconds after the treatment sequence begins, depending on the type and rate of the arrhythmia and whether the patient presses and holds the response buttons. Please note that you can be shocked if you are touching the patient when the shock is delivered. Do not touch the patient when LifeVest is in this mode. Allow LifeVest to complete the treatment sequence and shock the patient. The device will broadcast when it has completed the treatment sequence. The sirens will stop, and you will hear the following instructions.
Treatment has been given. Call your doctor.
Blue gel on the patient's chest and back is an indication that the patient may have been treated. LifeVest deploys blue gel prior to delivering a treatment shock. The purpose of the gel is to improve shock conduction and minimize burning. This gel should remain on the patient as long as they continue to wear the LifeVest WCD. However, if you choose to remove LifeVest and monitor the patient with your external equipment, the gel can be removed using water. The LifeVest system is a wearable defibrillator that is designed to continuously monitor the heart rhythm, detect certain rapid life-threatening heart rhythms, and respond by defibrillating the heart back to a normal rhythm. If you are required to treat patients wearing LifeVest, pay close attention to any alerts or voice prompts that may be broadcast. And remember, you may proceed with standard evaluation and treatment measures as you deem necessary. ZOLL provides 24-hour technical support for patients and healthcare professionals. For any questions about LifeVest or dealing with LifeVest patients, please call us at 1-800-543-3267. You can also learn more about LifeVest by visiting www.zoll.com.
So Mr. Jackson gets the education.
Yeah,
He
yeah.
understands.
Yeah.
They answered a bunch of his questions.
Mm-hmm.
Even gave him some education for if he ever has this happen again.
Like I said, they usually come and carry
Responders.
it.
Yeah,
It
so
really makes me feel good about it.
So responders come about. He knows what to do, what buttons to push if this thing starts to go off. He knows, some of the ins and outs of the ZOLL LifeVest.
Mm-hmm.
So best of luck to Mr. Jackson, right? Mr. Jackson has been through a lot of some life-changing events.
It is life-changing.
Mm-hmm. Life-changing events. We almost lost him.
We did almost lose. We actually did lose him for a little bit.
We did, yeah. We almost lost him for good.
Yeah.
We're happy that Mr. Jackson is at home today making a full recovery.
Right.
And the care of the paramedics, quick care of the EMTs and paramedics out there, being able to take care of this patient, give him the appropriate medications, and explain that. We gave him such a good experience that he actually wrote the director and said I appreciated what they did for him.
Did he have it on stationary? Only people his age would have stationary and watch the morning news. Just so you know.
Well, he was going to turn on the afternoon.
Didn't I tell you? Yeah. Like anything happened between the morning and the afternoon.
Anything that we need to tell the viewers for next time?
No. It was good.
I think that the new learning management system is going really good. We have a lot of users, a lot of people that particularly look at the website. We do want you to keep up. And
we're trying to do like tidbit posts.
We do.
Yeah.
We do. And I think those are pretty useful.
I do too.
They're not just this huge thing that you got to dissect, but
Dissect. Way to plug it there.
Yeah. I knew you'd like that. All right. Well, we appreciate you guys watching. I hope you have a good day, and we'll see you soon.
Bye.
Bye-bye.